So are folks joining?
Good to go, or do you want me to?
Pardon me?
Are you good to, are you gonna lead it?
I'm just going to say hello and no, and then I'm going to turn things over to you.
Okay.
So,
Cool.
yeah, great, good. Hello and welcome everybody. Thank you for joining us. And this is our third meeting of the Essential Support Workforce Advisory Council, which is statutorily created. And we're gonna continue the conversation that we started in late August around the kinds of data that are available and before kinds of data that are available and the other ways that we can continue to promote this workforce and also continuing to dig deep on what's happening at the state from the departments of Labor and Health and Human Services and how we know if we're making progress. So those are sort of the big topics we'll be covering today. I'm having some technical issues. I'm Jess Maurer. I'm the Executive Director of the Maine Council on Aging. And I thought we can start with and the chair of the council, but thought we could start with introductions of committee members. And then I'm going to have Catherine take over for a few minutes so I can try to deal with my technology problems. So why don't we move over to Catherine?
Sure. So just welcome everybody. Just to start off with introductions. I think there may be a few members from the public listening on. And so I will introduce myself and then just say the name of somebody else. And then we'll just go around the room. And then Bill, we'll turn it over to you once we get that done. So I'm Catherine Thibodeau. I am the Executive Director of Independence Advocates of Maine. We are a disability service organization, and I am here representing MAXB, the Disability Service Provider Association here in Maine. Donald?
On Dufour, I'm the Chief Human Resources Officer at Tri-County Mental Health Services.
Betsy, do you want to go next?
Sure. I'm Betsy Sawyer-Manter. I'm the CEO at Seniors Plus, one of the 5 area agencies on aging. We also are a service coordination agency for 2 parts of Maine Care for older and disabled adults, as well as a state program, Section 63. So serve the entire state of Maine in that regard. And I will turn it over to my colleague, Tom Newman.
It's so funny because that's what I was planning to do, Betsy, because on my camera, I was going to come up first. So thank you. I feel like I should come in like one of those Bama Rush TikTok videos. Hey, y'all, nice to be here. But I would say good afternoon to everyone. My name is Tom Newman. I'm the Executive Director at Alpha One. And we do some of the things that Betsy's great group does. We are a service coordination agency statewide. We're also Maine's only Center for Independent Living. So we provide a wide array of programs and services for people with disabilities statewide. And with that, I see Michael Smith. So I'll pass it over to Michael.
Thanks, Tom. Yeah, Michael Smith with Catholic Charities Maine, one of our chief program officers. And for this committee and group, I'll be representing our independent support services or our homemaker program. And I'll pass it along to Mary Jane.
Thanks, Michael. I'm Mary Jane Richards. I'm the Chief Executive Officer for North Country Associates. We own and manage long-term care facilities and residential care facilities and independent facilities for people with developmental disabilities here in Maine. Oh, and I will turn it over to Gloria.
Thank you. Hi, I'm Gloria Noyes, and I am the Assistant Director at Westbrook Regional Vocational Center. We're one of 27 career and technical education high schools across the state of Maine, and I'm kind of representing that population, so career and technical education. And I would love to send it to Bill.
Hello, everybody. I'm Bill Montejo. I'm the Director of Licensing and Certification within DHHS, and I am here at your request to answer questions.
Angelina and Dylan, do you guys want to just introduce yourselves and then we'll get back to Bill?
Hello, I'm Angelina Cluthis-Jean. I serve as the Director of Strategy and Innovation for the Maine Department of Labor. And today my role here at our committee is staff. So I'm your technical support. If things are going not quite right, please don't hesitate to reach out and I will make sure to help fix them, and I'm standing by to be supportive in any way I can.
Hi, everybody. My name is Dylan Murray. I'm the legislative liaison for the Maine Department of Labor. I am here today to give technical support to the technical support. So I think I'll be taking some notes and helping Angelina as she staffs this wonderful committee. So thank you for having me.
Great. All right. I think we got all of our introductions done. Thank you, everybody. And so, Bill, we are hoping to hear from you from the Division of Licensing and Certification around, what data is collected at your division, things that we are looking at how to crack the nut of looking at what the staffing needs are and what they are going to be within the state. That's part of one of our charges as this committee. And if that's enough to get you started, I will go from there. But if you have more questions, feel free.
Okay, well, first, a little bit of level setting is that the Division of Licensing primarily licenses and certifies agencies and facilities and not individuals. So we register personal care agencies, and as many of you are aware, in the last legislative session, there was a bill passed that gives us authority to work with ODES on drafting licensing standards for personal care agencies going forward. But we license assisted housing facilities, which is often confusing. It's assisted housing is the overall term that incorporates assisted living, which are private apartments that have kitchenettes, and residential care facilities. And residential care facilities, really the best way to think of them is dormitory style living for our geriatric population. So a residential care facility, usually there's a private or semi-private room with either a private bath or a shared bath, but living room, a dining room, all those are provided in a central setting and not in an individual's rooms, so to speak. And then agencies. We register some agencies and we license some agencies, both federally certified home health and state licensed home health under the home health care services provider designation. So in regards to data, if you're looking at direct care workforce, our data is really extremely limited to CNAs. We issue certificates of course completion to PSSs, but the PSS database is an old access database that is not able to be manipulated or provide reports. Likewise, we don't track or maintain data on agency or facility staffing. So we have no idea how many staff one agency has in comparison to another, or how many residents they are providing services to. Our processes involve us going out and doing licensing surveys or which are really inspections. And that's just a point in time look at how that provider is doing in compliance with the licensing standards and regulations at that time. So if we go to a state licensed home health care services provider, which is providing both nursing services, and the majority of them provide a lot of PSS services for individuals in that home setting, we could be there on January 1st of 2020, and they could have 300 clients and have sufficient staff to meet those needs. And 6 months later, they could have 3,000 clients. So we don't have any idea, and we don't track that data. So we're really rather limited in what we currently have and can provide. CNAs, we have a lot of data regarding CNAs because that's a federal registry requirement that we maintain within licensing. So we can tell how many CNAs are active, how many are inactive, how many are pending review. We can tell you how many are coming in from out of state, and we're working on a Tableau database that really can extract the data that we currently have and put it in using Tableau and put it in a portal that the public can view that will tell you where the out-of-state CNAs are coming from. That's kind of in a nutshell, the limits of our data. So PSSs, like I said, we issue the certificates, but there's no expiration on a PSS. There's not a central database that we could pull at any point in time and tell you we have X number of active or inactive PSSs. Likewise, I know in Angelina's email to me, she had referenced DSPs and BHPs, and those are not tracked within the Division of Licensing. That's kind of where we're at, and happy to, if I didn't touch on anything that you're looking for, Catherine, happy to elaborate more.
Great, thanks, Bill. And anybody else have any questions, just raise your hand or come off mute. Betsy.
Thanks. I apologize. I missed the last meeting. I was on vacation, but are we trying to determine like where the gaps are in data? Is that part of our exploring what kind of data that is available today? Because Catherine, I hear this conversation come up in many different forums, and there seems to be a way to sort of identify where what's the data that we'd really like to have, and what are the gaps in terms of being able to access it. So I guess that's a question I have about just generally this group. Is that within our mission?
So this is Jess, and I think that, and I'll just be a little bit more targeted, Bill. The reason I believe we brought you in, and I'm going to follow up on that last thing you said. And again, I'm very close to being able to join you all in this meeting, but there are two pieces. So one is we are, as Betsy just said, trying to get at not the number of workers we have right now. That's not, I mean, that we actually can sort of come to that number, or we even have sort of come to that number. But more importantly, how many workers, providers, agencies are trying to hire. In other words, and so one of the things that came up in our last meeting was, is there some government agency already getting reports from providers where we could tack on, are they already asking, like, how many vacancies do you have and what kind of vacancies are they? And if not, is there a report that we could tack a question on so that we could start tracking the number of vacancies that organizations have to sort of get at the number of workers we need to be moving into these jobs. So I don't know if that helps at all. That's the broader picture. The second part, though, is if you aren't an agency working with DSPs, direct service professionals, and behavioral health professionals, who's the licensing or governing organization for those, if you know?
So Jess, in response to the first question, the only thing agencies and providers are required to report into us is abuse, neglect, exploitation allegations, and in the assisted housing world, which are assisted living and PNMIs, any allegation of a resident rights violation. So when we do the survey, they're not reporting in on a regular basis staffing. The survey looks at primarily what is the agency. They really do a sample of what's the census within the facility, and are there enough staff to meet the needs of those individuals in the facility at that point in time. But it's not tracked on a regular basis. So, and I'm not aware of anybody within DHHS that is asking that question routinely or tracking that. So that there really is there's no report that we receive on a regular basis that we could look at adding, can you give us this additional information? In nursing homes and residential care facilities, and only in level 4 residential care facilities, they do look at census data, which I believe several people have gotten those census data reports, but those are usually 3 to 5 months old because it's based on the facility submission of that MDS. But again, it doesn't get the population, the bigger population that you're looking at, which are the agencies providing home-based services or the smaller residential care facilities. And I apologize, but could you rephrase or ask the second part of your question?
Yeah, just if you have, and you may not know, Bill, you may not know, but, you know, do you have a counterpart somewhere in state government that regulates DSP agencies, you know, direct service professionals? And conversely, maybe I ask Catherine, right, where do you send reports?
So,
you know,
yeah, just that I'm not aware of a regulatory agency that oversees DSPs or BHPs. I mean, PSSs are individuals. The PCA, the personal care agencies, register with us,
right?
But we don't track the staffing, and that, you know, the licensing piece, you know, that's something that is in the works. And certainly as we develop licensing and go through public comments, there's, you know, that would be a mechanism as you're developing the licensing rules for personal care agencies to add such a requirement for those types of agencies to report. That would impact the staffing needed to handle that licensing process. So there's a direct, you know, the more you ask of the provider, the more the provider has to do, the more staff they're going to need, the more staff we're going to need to process. But as far as the other, we issue course completion certificates for PSSs, but the database was never designed to be able to allow us to extract reports, unfortunately, out of it. But for DHPs and DSPs, those are through Office of OCFS, Office of Children and Family Services, and the Office of Aging and Disability Services. And I think those may be like approved programs with contracted entities providing the training. So I'm not sure that they have a database or the ability to capture data regarding those individuals or agencies that are using those individuals. When we license a facility, and children's residential care facilities that are providing behavioral health would primarily be using the BHPs, they would be looking at essentially the same process we are. At this point in time, when we're doing your inspection, do you have the staff needed to provide the services? But they don't routinely track that census data or staffing data on a regular basis. And ODES, the Office of Aging and Disability Services, as the program side of the house, works with a lot of the agencies that and the individuals that they're serving and the staff, but also I don't believe that they have a database that tracks that information as well. So a lot of these certifications, it's really the educational program is approved and it's the training entity that is certifying the individual.
Do you do anything with the CNA data that you have? Is that used, or is that shared with policymakers or anything, or is it just? Or...
It is, and I will share with you that we are working to try. We've just gotten access to Tableau, which some of you may be aware of, and we're working to. We finally, after years, have got a really good comprehensive health planner who is working with us to utilize Tableau to make this data available on our website so that you can pull it. And Angelina, can I share my screen? I will give you a snapshot of what some of it that we are looking at. It says host has disabled participant screen sharing.
I have been able to. You have the power now, Bill, and all of you as panelists also do.
I have the power. That's dangerous. Can you see my screen for the
We can.
Tableau?
Yep.
Okay. I think I can zoom in. So this data that's here is now already about 3 months old, but this is a snapshot of what we're looking to do. And to put the CNA data that we have on the website so anybody can look at it, which tracks from, let me zoom out so we can get it. How many active certifications per year are we getting from 2013 of less than 1,000 to 2021, 2022, we had a huge spike of almost 9,000. And these are initial certifications. And then looking at the number of active CNAs in Maine by county. And then where are they coming? Where are the out-of-state CNAs coming from? Our data, the data is allowing us to track region, Midwest, Northeast, South. And then down here, which is really kind of interesting, and I'll try and zoom in so you can see it. The Tableau system allows us to pinpoint where are most of our out-of-state CNAs coming from. Interestingly, down in the Louisiana, Mississippi area, and Texas. We're getting a lot from Illinois. So it's, you know, we are exploring because of the amount of data that we get through the federal CNA registry, how we can utilize this data to make it more available to policymakers and also to all of you, so that you can access it and look at and say, where are the most CNAs in the state of Maine? We're also looking at how we can put out the data on inactive CNAs versus active CNAs.
Bill, when you say where they're coming from, that caught my attention for a minute. Are these agency staffing, like people are here, like a traveling nurse, a traveling CNA?
That I couldn't tell you definitively. I would say that's a reasonable assumption. But because the registry, when we're registering people, when they're coming in from out of state, we don't ask if they're coming in as an agency traveler or if they've recently moved in the state, and are now getting certified in the state. I
think that's an interesting data point because they're not permanent if they're, you know, typically they're not permanent if there's a staffing agency, and they cost way more too.
Explains that huge spike too, because I can guarantee you that's probably what that spike was, right? 9,000 in 1 year.
Well, a lot of the increase, let me share another one that Robert has provided. So this is Maine specific. This is from our CNA registry. So new in-state CNA applications that we've received 2018 on calendar year, we got 607. 2021, you see a huge spike. Now, incidentally, I believe it was late 2020, the Board of Nurses reduced the CNA hour requirements for CNAs from 180, which nobody outside of Maine could meet. So there was almost no reciprocity for a CNA coming out of state, to about 130, which allowed for increased reciprocity. And then we started seeing more out of, well, these are in-state, but then we started seeing more staff in-state, and we saw this huge jump in 2021. 2020, we went 354 out of state. When they reduced the hour requirement at the Board of Nurses, changed the hours, we saw a huge spike. And that is because it allowed for more reciprocity. In 2022, when all of COVID was really in full swing and staffing was an issue, we saw this more than double. This is currently year to date, we're at 3,800 as of September 20th. But we've also seen a steady increase, except for this year, in in-state applications. The hard part is you can make the assumption that these are agency staff, but until the registry is on a 2-year cycle, so until we see the renewals, we really won't know. If we see a huge drop in renewals, then it would be safe to assume that you've had a lot of agency staff who came in and left. What we are seeing, and I can't give you the data, is that some of the out-of-state people that have come in and applied for initial are renewing. So that's, to us, you know, a good sign.
Bill, So, I mean, sort of it sounded like from what you said that, you know, the data on the PSS side isn't as robust. I mean, you couldn't create the same sort of map with PSS.
No, no, because the data for the CNA originated with a federal database and has been expanded, versus the PSS was originally an access database, because we are only issuing certificates, not tracking these individuals. A lot of this data on the CNA is mandated by the federal registry, CNA registry requirements, which is why the system was set up and we were able to get this, because it met federal requirements from the get-go.
And you said you do license PCA, personal care?
No, currently we register them, and the only requirement is that they pay a $25 registration fee and that they do a Maine background check on their employees. There are no other requirements for personal care agencies, and that's why the last legislative session, the legislature approved granting the authority for the creation of licensing standards. And we are working with the Office of Aging and Disability Services on those, and there will be a listening session that ODES will do with the Provider Association. We've had some in the past as we were contemplating licensing standards. But the legislature directed that we now develop the licensing standards. So there will be a MAPA process and public input and provider input and as we go forward with those standards.
Jess, I have a question for Jess, if you were finished, Bill.
Yep.
Like Betsy, I also missed the August meeting. And so I had that same question. So maybe you could refine a little further, because you know that Betsy's agency and my agency are required to track unstaffed hours, and we report that to ODES, and ODES has the unstaffed hours. But I'm not sure I quite understand what further information were you hoping to achieve that looks like we don't have with the Department of Labor that might be helpful?
So we were talking about the potential of surveying organizations about vacancies. In other words, the number, creating a baseline. So yes, we have numbers of unstaffed hours, but without understanding whether those are one person with 40 hours unstaffed in Piscataquis County, or 30 unstaffed in Piscataquis County that could, you know, maintain 4 workers, without understanding where they are and how many hours they have. We can't put together a full picture of how many workers are needed. And so we were saying, well, maybe another way to crack the nut, right, is to say how many vacancies are there currently to create a baseline. And so we were talking about, could we do a survey, right, of all provider types to say, in this moment in time, it's just a moment in time, you know, how many, you know, what are your current staff vacancies, just to understand, right, the magnitude of, and it's just what it's not even that useful of information, because it's what that agency feels like it needs to hire to meet the demand that they are seeing, but it doesn't necessarily meet all of the demand, you know, either the unmet demand within the state served population, or the unmet demand that's out in the general public for elder care services.
But I could see if we already had those as a ready report, it would add something. I see it.
Yeah.
And I think it's a combination of both. I think it's combination
it is.
of unstaffed hours, and then what the agencies say they are in deficit in terms of staffing. I think depending on the population, it's easier to capture it from the agencies. I think for the home care that we do, Tom does and I do, we often will put out staffing requests and get no one respond to it. So though if you didn't know that data, you would be missing a piece of need.
No question about it. And that's, you know, so why Bill is sitting here today was that both I think Angelina and Kim Moore and also DHHS thought maybe we should explore whether there were state agencies that were regularly collecting data from providers, and if we could, right, add a simple question on, like, because I know, Catherine, you were saying you have to put a lot of reports in to DHHS. And so the question was, is the data already collected, and could we just get it somewhere? So that's why Bill is here. We were just exploring what data he had, and now we know he's got this very cool map of CNAs.
Yeah, I think that's extremely helpful.
You got the preview look of that, but that's what's coming to licensing soon for the public to view. But interestingly, Jess, we have a lot of data on CNAs, but I couldn't tell you that data down to this agency specific level of, what agency has staff or sufficient staff or doesn't.
Yeah, I think though that the learning here from Bill and Jess is that if you're going to have, which sounds like it's in the works, if you're going to have a regulatory process for home care staffing agencies, you can make this type of reporting part of the requirement. You could set it at intervals that make sense. Then we have hey, Washington County, there's no agency, there's one agency. Well, we know how unstaffed we are up there. We can't get anybody. And we could go from there. The secondarily, and then I'll mute, is I think the CNA registry is fabulous because they're already sourced. They can serve as a PSS. They don't need further training. They're already qualified, and they can do self-direction work. And if there's a registry, then there's access. So I think that was helpful information on that front as well. When we recognize the goal here is direct care workforce for people in the home and based community services. So that was helpful.
Absolutely. So I think, do other folks have questions for Bill before we turn things over to Karynlee?
Steph, Jess, one more thing that I will add is in the last legislative session, it was LD 451 was a bill that passed that requires licensing to add requirements to temporary nurse staffing agencies to report certain data elements to licensing that we then have to provide a report to the legislature on. That doesn't take effect until the end of October. And so we are still working on the data that the legislature directed us to obtain. A lot of it is where staff are being utilized and the costs associated with that, but it's not, I don't think it would get specifically to the needs that you're looking for where they are, where in certain areas of the state.
Well, I appreciate, I mean, I'm just very impressed by the way that there's this little slice of the world that can show us this, because I mean, it means that eventually we have the capability of putting other data sets together and looking at them. So, I think it's really helpful to know what you're doing, Bill. So thank you. I appreciate your time today. And I know you've got to run to another meeting.
I apologize, but unless there's anything else, I've got 3 minutes and then I do need to sign off. So,
and any other questions for Bill?
Thanks, Bill.
No worries. If you think of anything, reach out. Thank you.
Thank you. Thank you so much. So, I know that Karynlee Harrington's here from the Maine Health Data Organization, and I want to make sure you're here before I go further.
I am here. Good afternoon.
Nice to see you again, sort of. So you've been listening in a little bit about some of the inquiries we are making, but essentially this group has been tasked with monitoring the efforts of of the state and others in relation to growing what we call the essential care and support workforce, which are people who provide care and support. So activities of daily living, instrumental activities of daily living for different populations of people, older people, people with disabilities, intellectual disabilities, behavioral health challenges in all sorts of settings, in their homes, in assisted living, in group homes, nursing homes, that sort of thing. And one of, as you've already heard, one of the questions we're really trying to figure out is how many workers do we ultimately need? So as you heard from a conversation with Betsy and Tom, they are care coordination agencies that just are focused on care for older people and disabled, some disability in two sections of the Maine Care. Well, it's actually section 19 and section 63, which is a state funded program. And Betsy is trying to say something else.
And 96.
And 96. I was getting to the 90s.
Don't forget 12, Jess. There's actually four
Well,
for us.
don't forget 12. There you go. There you go. 4 sections for older folks and disabled folks. And so we know the number of there's a report that tells us how many people are not getting any staffing or are only partially staffed. We have a report and the department has all of the information about the number of approved hours of care and the number of hours of care that are going unstaffed and where these people live. And so one of the questions we were trying to figure out is, do we already have, like through your organization and maybe not, the capacity to take that kind of data and turn it into at least a theoretical view of how many workers we would need to bring into this workforce to deliver care to that number of people who are currently not getting care. And currently the number is about 15,000 hours a week of care that is going unstaffed. So I just thought we could invite you in because you're one organization that is doing really very good work around health data in Maine to say, who are you? What do you do? And could you help us crack this nut in any way?
I'm excited to be here, and I'm not showing my video for 2 reasons. One, I keep getting a message that I have unstable video or unstable internet, but more importantly, I'm a hot mess today because I've been working on a report that is due. I've been up since 5 a.m. and I am working at home and essentially rolled out of bed, but I do want to put a face with a name. So I'm going to start my video for a second. And normally I don't look like this, but hello. I'm going to now stop my video and talk to you about the Maine Health Data Organization. And I know you've got a lot to talk about today, so I'm going to try and talk very quick and answer more of your questions or have more of a discussion. And I'm also happy to continue this conversation either in another meeting or offline if that's appropriate. But the bottom line is the Maine Health Data Organization is a state agency. We are independent in the sense that I serve at the pleasure of a board of directors. I'm not part of the governor's cabinet. We are not part of DHHS or the Bureau of Insurance. We are independent. The board of directors that I am responsible to serve today are a multi-stakeholder group of folks. And essentially they represent hospitals, nursing homes, home health care, providers, employers, consumers. So, the range of different stakeholders have a voice at the table. And our statutory duties have really expanded over the last 10 plus years since I've been with the organization. But essentially when MHDO was started back in the early 90s or mid 90s, it was established as the entity responsible for creating and maintaining a useful, objective, reliable, comprehensive health information data warehouse that was meant to be used to improve the health of Maine citizens. And over the years, we've added to those responsibilities where we are to promote the transparency of the cost and quality of healthcare in the state. And there are numerous ways in which we are required to do that. But essentially, we collect data from all the commercial payers in the state, claims data. We collect data from MaineCare, Medicare, again, for claims transactions. We get all the services, diagnosis, providers, everything, information about the patients themselves that we then de-identify, but people can do analyses on demographics. We're getting information so that people can look at healthcare disparities and things like that. We get data from hospitals on every single encounter. So whether it's inpatient, outpatient, emergency department. And over the last couple of years, we have, and all of this data collection is governed by rules. And some of those rules are routine technical, where my board has the authority to adopt what we're proposing. Or we have major substantive rules where my board does the first step, and then we have to go to the legislature. And over the last couple of years, we are now collecting data from nursing facilities. So we're expanding the types of entities that are reporting data into MHDO based on policy that legislators are passing and or interested in. And one of the other areas that we've been really focused on over the last couple of years is in the pharmaceutical space. So we're now collecting data from manufacturers, wholesale distributors, and pharmacy benefit managers. And I share all of this because although I don't think we have the data today to address what it is that you're all looking at. We have the structures, and I think, Jess, this is what you were saying earlier, to talk about future data collection. And I come from the private sector, although I really can't say that now because now I've spent more time in the public sector. But what I've learned is we can't move as quickly in the public sector because of rules and the processes that you have to take to adopt rules, et cetera. But what we can do is plan and execute on the plan so that ultimately we can make things happen, based on all of the different requirements we have with timelines and things like that. So for, in the past, just to share with you, in one of our rules, which is a major substantive rule, it's chapter 270, where we collect our quality data metrics from hospitals. And now I was telling you the nursing facilities in the state. Years ago, we collected data on staffing ratios for nursing, okay? And it was, very administratively burdensome for the hospitals. It's not standardized. I mean, it took some time to get to the point where there was agreement on what we would collect, and then we started collecting it. And there was a point in time when we stopped collecting that data and we replaced it with outcome measures. So, one of the big discussions was, like you were saying, it's very difficult to figure out what is the right ratio, like what's the right staffing level or how, right? And so one of the things that we learned through this whole process was outcome measures. So looking at your falls with injury rates or looking at medication errors or things like that help you figure out, where you may have some issues with potentially staffing. And so that's where the focus of our rule chapter 270 came in to play, was more looking at outcome measures, not so much this sort of manual reporting around hours that people were or unfilled hours, or I can't remember all of the specific, but just when you were speaking, it reminded me of that. So again, we don't have that structure. I mean, we don't have those requirements in place now, but we have a rule that we could use as the vehicle to look at starting to put together a data set for a specific group that you might be interested in, or the legislature is interested in better understanding. So I'll stop there. I mean, I could go on for days about what we do, because we have, over the last 10 years, I think really made some huge improvements. We had an awesome starting point when I came on board, and then we were able to take it to the next level with support from governors and from the legislature, from my board. So I'll stop there and answer any specific questions that you might have.
I definitely do, but I'm going to see if my colleagues have questions first.
Why don't you go ahead, Jess?
All right, great. So I'm curious about the outcome measures, because that has been, and particularly because you get health data, Medicare and Medicaid claims data, I think. And one of the things that we know for sure, because the Maine Hospital Association has been yelling about it, and Maine Health has been yelling about it, North Light's been yelling about it, is that this lack of workforce has resulted in when people are injured, sometimes because they don't have care, they go to the hospital, then they can't get discharged, and they are sitting in the hospital for extensive periods of time. And it's been pretty well documented at this point. And I don't know if you've seen it, but now you're now on the list of getting a briefing from the Maine Center for Economic Policy. Just did a report about 5-6 months ago on essentially the cost of not solving our workforce shortage, and actually spends a fair amount of time looking at the data we do have. But I have been very, very curious about doing an in-depth report of the people who aren't getting care, and what's happening to them. Are they, from a purely financial, because we can't see behind the curtain. We can say they're not getting staffed, but we don't know if they're not getting staffed and are getting hurt, are costing us more money because we're not putting in the least expensive care available. Michael Smith has the least expensive support available to people. He runs the Homemaker program, and has an incredible wait list. And so, are people going into facility care, which, they might need, which is exactly appropriate, or they might not need, and they could stay home, or they want to stay home, but they're, going into nursing home care because they can't get home care, and taking a bed that somebody else could really need, and not be able to get into, and B, they may have a choice for being at home, and so it's again at a higher cost as well. So just curious if you feel like the that is, from a quality point of view, something that you all could look at. In other words, people not getting care, and what the downstream effect is.
So I think that, MHDO is responsible for the data collection, and over the years that, as I mentioned, the request for us to actually do reporting has expanded significantly. And so we are now reporting out on, issues around the state of healthcare associated infections in the state of Maine, for an example. We report out on, primary care spending in the state compared to total spending, or spending for behavioral health care. I'm just trying to give you some examples of things. We do a lot of reporting on prescription drugs. All of that is identified in statute. And so there is a requirement and funding dedicated to this work. And I will say, for anybody that is doing analysis of these types of data, it is not inexpensive, and it's time consuming. Not to mention, the data isn't always available. And so although MHDO collects data on the number of patient falls per patient days in the hospital, we collect data on falls with injuries. We collect data on pressure ulcers. We don't do any, at this point in time, analysis on why those things happen, or we put the metrics out there. So on the website, you know, we have, and if I could find this quickly, I could share my screen, but we have, you know, essentially all the hospitals, right? And their rates of falls, pressure ulcers, healthcare associated infections. We do a lot of collection of data around HAIs. We're now implementing surgical site infections for knee and hip replacements. I think just really I hope over the next 10 or so years, we figured out now the systems to collect data. I think we've got to do a better job at figuring out how to take that data and turn it into actionable information. And I think part of that is linking different disparate data streams, because the person that was talking earlier when I first came on, you know, he may have some data that linked with some of my data may make for a more comprehensive picture of something. And so we've had some success in doing this. We're now required under statute to take data from the cancer registry and vital statistics, and I link it to my hospital data. So we can now see somebody with cancer, what happens relative to their history with other things within the hospital data or claims data. We do this all in a de-identify. We don't want to know who the people are. We don't care about that. We protect the identity of people. I want to be really clear about that. We just want to know what's going on with individuals based on, you know, certain demographic profiles, etc. But anyways, that's a long way of saying that, you know, can I tell you today we could do that? No, but what I can tell you is I think we could build out that capacity if that were something that the legislature instructed us to do. And Jess, you're on mute.
Yeah, I was going to say, and just FYI, and I see if Tom has come off mute, so I'll let him have the floor. But this advisory council has the authority to make recommendations about legislation. So we can potentially do that. So Tom?
Yeah, that's where I was going, is that it sounds like there's all kinds of data there. You know, isn't it coming back to us to what can we use there to in support of the brief? That, I mean, basically what I know exactly what's going to be persuasive to the legislature that we can use. You already have all kinds of data there. It's not that we need more, it's that we have to figure out this group how to use it. We know intuitively that people prefer, or many people prefer, home and community-based services to residential care if they can manage it. We know that there are people who have unstaffed hours. What we don't know is what are the negative health consequences of that insufficient direct care workforce, and the financial. What's the cost difference? We know anecdotally, the nursing homes or residential care costs more to the state than home community-based services, but we don't really have some data to support. So I think you're on the right track, just looking for data to support that brief of things that if we're down in the weeds, we already know it. But up at the policymaking level, we need some evidentiary support for the brief. And I think this data pool could provide some.
Yeah, and I mean, clearly, Karynlee, you would need more data, but the data is all there. And the question would be, but so again, and I was having technical challenges, so I don't know when you joined, but this is a group of folks who have come together, who are serving people with, I think I did say this, behavioral health challenges, intellectual disabilities, as well as older people along the full continuum of care from a homemaker all the way to nursing home level of care. And so for, sort of the challenges are different for different populations. For the older people that I mentioned, there's never a wait list for Section 19 because you have to be technically poor and medically needy, and we have one of the highest, sort of medical needs in the country. So it's very hard to get in to a nursing home level of care. It's hard to get into a nursing home. People are always afraid of like they're going to put me in the home. I'm like, no, they're never going to put you in the home. You're never going to get there because you're not going to ever qualify. Sorry. Like it cracks me up. Sorry, I digress. So it's really hard to get into a nursing home. So people in Section 19 are, nursing home eligible, and so there's never a wait list there. But we have all these people who aren't getting any care on that list because of the workforce shortage, and we hypothesize are some of the people who are then showing up in hospitals and staying there for a long period of time because they can't be discharged, who have elected to have home care, but then ultimately are, sort of forced into a nursing home care situation because there's no home care to be found. So that data source exists. What I think would be challenging, and Catherine, or others can help me, is the wait list data. And sort of who's on a wait list. Is that data something that the department maintains? Is that data that is available that could then be looked at to see what happens? I know, Michael, like for instance, you have to call people on your wait list, right? So I don't, and does that data get transmitted somehow to the department?
So no. So we are the only one on the continuum that I'm aware of, at least in discussing with Nicole, in that we have an unstaffed list of which consumers that have been vetted and opened and to the program, so they're actually deemed eligible, and either had received services and staffing was not available and therefore unstaffed, which is a small portion. We're in the ballpark of around 400 or so consumers there. We have a wait list of which is well over 1,000 of folks that are referred to us, that have gone through some initial pre-screening. We've talked to them, but really are waiting their turn to have available staffing in their area and determining full eligibility process at that point in time. So the unstaffed list that I talked about before, that is communicated to ODE. So that's kind of like Tom and Betsy, the same sort of number of consumers, unstaffed hours that you could backtrack, easily for us, because we have a nice set 2 hours worth of time frame, the number of staff that you can full-time or part-time or on-call staff that could fill that role. But it's a small portion of our wait list, of which is not communicated to ODE and is a much, much larger part of the continuum. And part of that is just practicality of we don't have the staffing capacity nor the funding from ODE to be able to regulate that unstaffed list, because with that contractually, we would have to do all sorts of ongoing assessments that we don't have the staffing capacity to do. And so we're opening as eligible. If that makes any sense.
Yeah. Catherine, I saw you come off mute.
When you check in with the people on the wait list, what are you checking in on them?
So it could be a number of things, we're always trying to uplift the self-direct option, right? Is there anything change in that as a way to get services much more immediately? Other than that, has anything changed on their end? Checking how they're doing, try to connect with community supports that might need it. Those kinds of things. Again, and part of anything changed too, in terms of, are they no longer potentially eligible? We look at, maybe 5 or 6 sort of bullet points in terms of income eligibility and the like, and because we don't want someone to be thinking they're on this list for what could be a couple of years and then find out, hey, you're not actually eligible 2 seconds in, right? So this is a way to continue every quarter, every few months at least, to check in for that as well, to redirect and sometimes doing higher level care referrals at that point as well. So it's just trying to help kind of move things along the continuum and that well-being of them. Some of them get a little upset as why you keep calling and tell me I don't have staff every month, for months on end. But for others, it can be a helpful check-in because they haven't talked to anyone else in the interim.
Okay. Well, I think to me, it's kind of, the idea of like people, like looking at the people waiting for care, whether it's some care or a lot of care or whatnot. It just doesn't seem like we're going to get some kind of data on how many staff we have and how many staff we need. And I really like Karynlee said, which I think is so true, that really doesn't matter. It's the outcomes for the individuals that really in the long term matter, you know, and so I don't know, I think that's kind of an interesting way to, you know, I don't know. I just think it's, to me, it is such, there's so many different people. I mean, if there was a way to bring it all together and make it all make sense, but it would take, you know, it's not impossible, but that's a lot of will to get meaningful data across all the essential service workers, you know, across the wide variety, and some that are very already, you know, CNAs is being collected at some amazing level, down to homemakers, which there probably isn't a whole lot. There isn't a specific, you know, certification. So I don't know. It just seems like the more and more we hear and talk to different entities, I guess more of a discussion for the committee, the harder that, you know, that desire to sort of know what's out there and what's needed out there from a worker perspective seems harder and harder to achieve.
It feels like that, you know, for me, there's like, you know, you talk about the outcomes, and, you know, concern I have, and maybe this is more of a research study, is I would like to know what the impact is on people who aren't getting a worker versus someone who has a worker, and what are the, you know, what kind of health declines do we see? I mean, I have some hypotheses that I would probably throw out there, that, you know, you probably see faster health declines. You probably see less potential independence. You know, is there more depression because they're isolated? I mean, I have some hypotheses about what are some of those sort of health indicators might be. So, you know, there's a cost. I guess what I'm trying to say is there's a cost to people when they're not sufficiently supported in the community, whether that be someone with an IDD diagnosis, or it's somebody with a physical disability, or some other person needing assistance. So, you know, I'm sort of curious, and so conversely, I guess you would also study those folks who have had a stable worker, who have been able to be taken care of in the community, and what do their same health indicators say about those folks? So I don't know. I mean, maybe we're going way beyond the scope of this committee, but or this task group. But you know, there's costs that I think you could identify, and I think, you know, our friends down at I can never remember the place just down in PHI, that, you know, they've extrapolated some of this information. So, you know, there's a cost, and then there's a cost. So if you talk about getting a cost of getting data, there's a cost of not getting the data, I guess is my point. And I'll get off the soapbox now.
And I'll just say, Catherine, and I think it's both. It's not one or the other, because we need to understand what the human cost is, which we really haven't driven. I mean, this is the first time we're sort of talking about the fact that we have an organization that could help us understand what the utilization, the healthcare utilization is, the outcomes are for people who are not getting staffed when they need it and are on wait lists for care and support. So I'm going to come back to Karynlee. I hate for you to have to, but I'm just going to say, follow my sentence down here. So there you have it, but we still have to say, so then what do you do about it? And the answer is we have to increase our workforce to be able to meet the demand for this care. And that is exactly why this committee exists, is to, sort of just as by way of reference, right, to examine the level of needs in the essential support workforce, including entities funded by the state and through Maine Care, and, to make recommendations about, recruitment and retention of essential support workers, monitor essential support workforce shortages, and the expansion of the essential support workforce, and then make recommendations about further research that's needed, as well as make recommendations related to legislative action. So what I am hearing from you, Karynlee, is that you are a statutorily created and funded organization controlled by an independent board, which is really great. And so can you remind me again, because you said the statutory site, what your statute authorization is? And then I think the second question that I have is, would you be willing to work with us offline, maybe a smaller group of us, to think about crafting some legislation then this committee could consider for recommendation?
To answer your first question, we're governed under Title 22, Chapter 1683.
Great, thank you.
Okay, and although, the title is within DHHS, it's always confusing to people because it's in there, but we're still independent. And as far as chatting offline, I'd be happy to do that. We typically, I have to be a little careful about getting really involved in drafting legislation unless I'm going to bring it to my board, but I'm happy to be a resource in terms of data, like not so much on the pulp, but what kind of data. And I think that's what you're asking, is for that type of expertise.
Yes, absolutely. Yeah, not about this. I'm thinking about what I hate to do is to take everybody's time at the legislature, because you write a terrible bill and you come in and say, well, we can't do that.
Yep, I gotcha. And what I'd love to do, as I was listening to this conversation, is, if okay with you, I'd love to bring in, I have a contract with the folks at the University of Southern Maine. And I sort of wonder if in some of their work and potential grant opportunities, if this is something they've looked at, or not maybe exactly the questions that you're asking, but if there's some expertise that they have that could help. So I'd love to reach out to the primary point person that I deal with over there, just to ask if she's familiar with, because I do think that that's always helpful if there's anything that's, sort of already been done. We did a huge lit review and then just research on like what's going on with nursing staffing ratios when that whole debate was going on. And it was just helpful to see how others are thinking about it, and or if they've already started to collect data or whatever it is. So we could certainly, I think, do a little work there to help you out.
Yeah, and my yes, that'd be really terrific. So if you could reach out to that person. Can I ask who that is? Just curious.
Yeah, Kim Fox.
Okay. Yep, I know the name, but I was figuring it's and this is a data person there, right?
Oh yeah, and so Kathy McGuire might be the person that Kathy's been working with our data for decades. And she's recently retired, although you never really retire in Maine. So she retired full time, but she's doing consulting work with us. And, she's really got the institutional sort of knowledge and memory. So I work with this team with the work we do with primary care and behavioral health care spending analyses. So anyway, so I'm happy to see if they've got any insight.
Great. Yeah, no, this is I think this is very helpful. Very helpful. So I think that would be a good next couple of steps, and then certainly come back to this committee. December will be the next time we meet. Is that right, Angelina? Yeah. Do we have a date?
Our next meeting is scheduled for December 20th, but as we get into that section of the agenda, I'm curious if that's a good date for people, because in proximity to the holidays and potential flexibility to change it to December 6th. But I can wait for my pleas of logistics until the more appropriate time.
Yeah. Well, I just was curious. So our next meeting is December. So I think we would work in the interim with Karynlee about what's possible in relation to what we think would be useful, and then a group of us could work on some potential legislation and see where that goes. Does that? I just want to take the temperature of the people who are here.
I think meeting with Karynlee makes sense, and then taking it from there. Yeah.
Great, perfect.
So can I just ask before I jump off, in preparation for that discussion, is it possible either Jess or Angelina to just send me an email framing up I don't know if it's the ask or you know what I mean? So that when I'm talking with folks at Muskie and we're kind of doing our own research and thinking about this, I've taken notes. I've read the LD. I just want to make sure I've got it right, because I feel like there's been a lot of stuff.
Well, yeah. Well, I will tell you, and I think we won't get off of that kick. There's two questions on the table, and those questions are both really critically important. The latter of which is really the primary focus of this advisory committee is. But the first is sort of like, again, focusing on what is happening to people. What is the human cost of people, really languishing on wait lists and, or not getting care that they're entitled to get. And then, what are the downstream costs, right? I mean, what we don't know, and I think it's just a fascinating thing to, again, Betsy says, I have some hypotheses too, that some of the people who are taking up beds, at Maine Health and Northern Light systems are people who are supposed to be getting care and aren't getting care. I'm just guessing. And that, if we've got a real systems problem, i.e. people who aren't getting the care and support they need, causing, incurring health problems, going into healthcare, not being able to be discharged, going into nursing homes where they, really shouldn't have been in the first place. Again, taking up beds that other people really need because we need quality nursing home level of care. Then, we have a real systems problem that starts at this very end of not being able to get a worker to provide the support that we need. And so that's one question. It's like, what is that? What does that look like? What's happening with this population of people who are not getting care? But then, the other piece is really what's the predictive modeling in relation to how many workers we will need to solve that challenge. And what are we going to end up having to pay in a competitive market for lower rate, lower earners? What is the competitive market rate we're going to have to pay to attract people into those jobs, get a sufficient number to meet the demand? I mean, I think that is, and not like we're going to solve, not like the answer is $200 million and we're going to put that bill in next year to get $200 million. It's to say, this is what we need. It's like this view of, for the next 10 years, we're going to have to grow this workforce to this level, and it's going to take a bit. And it's going to take education, it's going to take benefits, it's going to take quality, it's going to take, income, it's going to take a whole bunch of things. But we have to understand, we don't have any idea. We don't have a baseline, Karynlee, and we don't know how many. We have a sense of how many workers there are, but we don't know whether anything that the state has done, and the state has done unbelievable things to attract more workers into this workforce. We don't know if it's been successful. And, sort of by anecdotal accounts, it hasn't been. So we really need to understand where, sort of how we're going to grow this workforce, but we don't even know, some of the basic data. So those are the two big questions.
Okay, I think I got it.
But I will send you an email. I will also, if you would so allow, take 30 minutes, 20 or 30 minutes of your time to also give you a briefing by MESEP of the report. This committee got a briefing at our last meeting of that report, and there's some really great data, but I think, it'd be a helpful place for you to see what's already been done.
Yep, that would be great.
Great. Any last questions for Karynlee?
Thank you for coming.
Well, thank you for thinking of us. I really, feel like the way people use data 20 years ago when MHDO got started, 20 plus years ago now, and the way we'll use data 5, 10, 15 years from now will be very different. And it's building out the capability and the functionality and all of that, because again, collecting data just for the sake of collecting data does nobody any good. We've got to be focused on data collection that actually is actionable and will improve on, what it is that we're trying to improve on. So thank you for, again, thinking of us, and look forward to future discussions on this.
Great. Thank you. Thank you for joining us.
Great.
Bye. Bye-bye. Phew. Thank you. So I think we'll move back because we've got a little time now, but between now and when our next person who's going to give us some information is going to join us. So maybe take the time to have a little update from folks. And not to put you on the spot, but I'm gonna start with you, Michael, just to hear about how things are going with the Homemaker program. And I didn't get to dive deep into this when I heard this yesterday, but I'm really curious if you could share about the concerns that some workers are unwilling to work with some clients, and why that is.
Sure. So kind of, go ahead.
Oh, I was just Jess. Dylan also is wanting to give us an update on the website, which I think would be great. So before we go to our next speaker, let's try to remember to tap into him. Okay.
You want Dylan to jump in now?
No, go ahead.
Okay. So as I had shared with some of you yesterday, so our Homemaker program, again, this is sort of the frontline staff that are going in to provide cooking, cleaning, laundry in the home, help people stay in their homes, places they want to be, versus, like you said, just moving up to a higher level of care that would have a much higher cost associated with it in terms of the actual dollars to provide the service. But also, again, more importantly, just the quality of where they want to be, right? As I shared yesterday, prior to COVID, like all of us, we had our numbers much higher for this direct care workforce in the 130 range, which still wasn't sufficing the needs, but certainly was at a much higher rate. And of those 130, I wasn't the director at that time, but I would say, at least anecdotally, those staff were working at a much higher number of hours, serving more consumers than our current workforce, of which we are down to 80. And of that 80, really for our end, to cover costs and to really provide services, we're looking for each homemaker to at least and minimum serve 6 consumers a week, which is 12 hours. We have about 20 of our staff meeting that threshold. The other 60 are below that, serving 1 or 2 or 3. Again, this is outside of our self-direct option, which just hovers around 400 or so consumers there. So it's a very dilapidated workforce when it comes to providing the services, not only just the number of actual staff doing it, but the quality or quantity of work, that they're able to do when it comes to serving number of consumers. And then it's sort of exacerbated by, to your point, Jess, around as these wait lists elongate and people are waiting longer and longer to get staffing. becomes much harder for our current workforce to then be able to go in and be matched up for actual services due to the degradation of the homes environments which they are. I mean, they need these services. That's why they're seeking and reaching out for them. But if they're going upwards of a year without that, the environment in which they're living in is becoming really inhabitable, unfortunately, in terms of the environments, which could involve massive amounts of hoarding to feces, animal and human, non-working holes in roofs and the like. And so that sort of, to your earlier point, Betsy, around just sort of the quality cost here, or the human cost of that, is just astronomical. And then these are the folks that need it the most, that then don't have that entry level, someone to walk in to be able to provide that service. We don't have that frontline staff member that's willing and or able. It really goes beyond basic 2 hours a week of actual home care to a much higher level need, because it's gone so long unattended, unfortunately. And so that's become almost a subset, if you will. We haven't officially tracked it, but I've been trying to talk to Oates too around sort of this unwilling provider. I mean, we've got a growing list of those that just they're on a staff list, but they've been on staff list for a very long time, not because sometimes we don't have the staff, but the staff aren't really able to meet the needs of the consumers there, which is really unfortunate. It's not necessarily a cost piece for it, as much as just the environment that they're in. And so that really, a lot of times will go to sort of an APS referral, of which, again, if the consumer is choosing to live in this environment, unless something really drastic happens, it's got to hit absolute rock bottom before. And then at that point, they're being moved right onto a higher level of care that, again, comes at a much higher fiscal cost that you talked about, Betsy, as well. And so it's not the right cycle we want to be heading in for any stretch of the imagination. So we're trying to troubleshoot on our end as ways to try to address that. But it's definitely been growing over the past several years as to these folks that are in those more dire situations, as directly related to the inability of staff to go in for that. So on a positive side, I don't want to paint a completely gloomy picture here. We are in the process, or we have hired what we're calling a hiring specialist, someone to really focus on our direct care workforce. Despite the low numbers of actual workers and the low number of hours that they're working, there's also been an extremely high turnover rate, of which the applications are coming in quite steadily and heavily, but we're trying to wean those a little bit more effectively to make sure that the staff know what they're walking into, because a lot of times, to your point, Jess, we're investing all sorts of HR and supervisor time up front to screen, interview, background check, train, and get ready. And they go into the home 2 seconds later and say, whoa, this is way more than I thought. I was, sort of sold a bill of goods, so to speak. And, they're going to leave. And that actually plays out in that I think it's over 60% of our homemakers are leaving within the first month. I mean, the turnover is absolutely astounding as well. So trying to have someone really own that process of not, individual regional supervisors, but someone to really own the hiring process and training process to get, albeit fewer, but hopefully have some longevity and staff that can serve more people and stick around for that. So that's kind of our area of focus right now. And she's only been with us for a little over a month, but we've got 2 full-time homemakers and 2 part-time hired, which really would knock out probably almost the amount of work that those 60 staff that are really serving 1 or 2 conservers would do. I mean, again, it doesn't take much to really move the needle, unfortunately, where we're at. So we're hoping to see some positive trends. Now, hopefully these folks will stay. But that's the direction that we're really trying to focus on when it comes to our workforce. Sorry, a little long-winded, but hopefully that's helpful.
Great. Any questions for Michael? Mary Jane, you want to go next?
Sure. We continue to have significant nursing shortages. We have had some luck in hiring CNAs, and some facilities The lifting the vaccine mandate has helped us to hire some ancillary departments. Our dietary departments were really hit hard by the vaccine mandate. So by lifting that a couple weeks ago, we've started to see some staff coming back. I was hoping for droves of people coming back. That didn't happen. So we too, like Michael said, we're looking at hiring a recruiter, hiring specialist, whatever you call them, to really make it their focus. We do have our support specialist out front that calls every single applicant to get them to come in. And it's just such a small percentage that actually comes to fruition from the application to an actual hire. Some of them are, beyond criminal. So it limits what we can do with them. And then we have seen some success in our residential care settings that we've been able to rid agency in those units. Most of our facilities now are running with their own staff. So that is very, very positive. And like I said, we still have quite a few nursing vacancies, which is scary running up against the new CMS, what they have sent out for what this CMS will be requiring for our staffing levels. 85% of our facilities will not meet those requirements as they're written right now. So that has kind of struck us all like, here we go again, but we'll continue to work and fight through American Healthcare Association to see if we can get those changes so it's a little bit more palatable for us.
Thank you. Any questions for Mary Jane? How about Dawn?
I think I neglected to mention the programs that are relevant for us in here. We have 3 community housing programs. So we have residential service workers that are working in those programs, as well as a lot of MERT-Cs working in behavioral health homes. So forgive me, but I'm taking some comfort in Michael and Mary Jane hearing some of the same challenges that we're all experiencing. But like Mary Jane, we've seen the tide turn a bit with our hiring of residential service workers, the MERT-1 folks. For whatever reason that might be, we're in a much better place than we were even 6 months ago, knock on wood. But similar to what both folks have said, we're seeing the same churn with applicants, and we're seeing a lack of follow through on that. It is frustrating. It is taking a lot of HR time and training time. And, so a lot of the administrative people are saying, look, this churn continues. So we're trying to address that. We've certainly retooled our salary scale structures. We've emphasize flexibility, which is one of our biggest selling points, and seems to be having some positive impact. Nurses, RN is a big hole for us still. We did a wage increase 6 months ago, and we're doing another one this month, trying to get to be more competitive, and it's difficult. That's more a factor of the number of candidates that are truly available in the state than anything else, But yeah, we're making some headway, and I like to see the work this group is doing. It's helpful, and maybe we'll see it continue to improve. Thank you.
Yes, you're on mute. Who are you calling on?
Catherine.
Oh, me. Oh, yeah.
Sorry, Jesus.
I wish I had something different to say, but I don't. It is for intellectual disability services. We do a survey twice a year at our provider association. So that's like at the just wrapping up. So we will have some actual more hard data on what people are experiencing as far as overtime. So we're seeing a tremendous amount of overtime being used. Really the same challenges. Ours is DSP, CRMAs. It is kind of like fits and starts. You might be looking good, and then you know, in a pocket of the state, and then it just sort of implodes, and it is very unpredictable and unstable. Right. So that is really, I don't think things are getting worse as far as staffing, but there's a lot of instability. It is becoming increasingly clear that we, you know, the world or the state of the US and certainly of Maine as it comes to work is something that has moved and shifted greatly during the pandemic and post the pandemic, and us in the caring industry are sort of left with like having to figure out how to retool or I don't know, you know, so, you know, I mean, I'm just preaching to the choir, but it's just becoming more and more obvious to us that we are not attractive to the worker. And like Michael was, I was really resonating, you know, when back in the olden days, one of the first jobs I had was working with people who, they were referred to as self-neglecting elders in the state of Massachusetts. And I just thrived in going into these environments, but you know, that was a whole different time. And so, you know, I think that is, trying to be relevant in the market is something that is going to become more and more of an issue, because we can, you know, offer only so much of something, and it's kind of different for all of us, right? We all have something that you know, well, there might be more flexibility in a non-facility based services. You know, there's more predictability in a facility based services, but you know, so like that. That's just something that we're seeing emerging as a bigger and bigger issue in the recruitment and retaining staff. So that's kind of what's going on. We'll have more in December.
See, I'm trying to be so good about muting myself, and now I'm just, any questions for Catherine? I mean, Michael, I would think you would be asking her for a job right now. Do you want to hire her?
I've already sent an application over. But I mean, it also makes me think too a little bit like what Donald's saying, just in terms of, you know, we're all raising rates. And I always think of my end is that, you know, I'm always trying to play catch up. I think, you know, as the workforce, you know, higher level of care moves up to a much higher level, high rate of pay, we feel like we're always behind. And certainly when we're contractually stuck with our rates, it's like we don't have much of an ability to even play that catch up game anyway. And so, you know, I understand where we're all coming from. We're all trying to, you know, the pay certainly is part of that, but it's just interesting how they can hurt against ourselves, even within the continuum here, right? As to one end can have the ability to move up faster maybe than others that can then really have a, you know, an impact. Now, and again, not others are always pulling from the same workforce pool. Let's, you know, and I'm not realizing that, but if there's any, you know, on the borderline of some of these, between some of these transition levels, care, like I'm going to go here or there. Well, if this one's exponentially being able to offer a lot more, that really hurt the one that's just a step below that potentially could, the staff member could swing that way, right? So it's just another reality, because we're not all moving up at the same rates at the same time.
And in the whole like totality of the workforce, we are all going after the same worker. You know, it's just such a small difference. And, you know, I think anybody would credential anybody if they came in the door and they wanted to work, right? And so, so I think that is, you know, I think that is another thing that where there used to be a big difference between, you know, a homemaker and a CNA, it's not as much of a difference, because I think anybody that needs a CNA would grab a homemaker in a heartbeat and take them through the CNA school. Like Northern Light is doing that at a rapid pace. And, you know, I don't know if there's larger, I don't know, Mary Jane, if that's happening at scale in nursing homes too, of the certification, you know, work to learn or whatever those programs are called.
Yeah, we definitely run those pretty consistently, although we have periods of time where it's hard to get somebody to even apply for taking those courses. You know? So ebbs and flows.
Yeah.
Betsy? Welcome.
I dropped off. I lost my internet for a few minutes. They're working on my lines out here. I don't know what they're doing, but I think they messed up. So for us, we too have had to hire a recruiter just for our care coordination function. And I think, this is a cost that also has to get thought about in terms of rates, is that it's not, it's harder to hire, which adds cost to doing business. So it sounds like all of us now have got recruiters that are working for us. I was thinking about Mary Jane, when you were talking about beds and others were talking about beds, we use respite beds for folks who have respite on their plan of care. And I know that's been it's been difficult in certain parts of the state to even get nursing homes to have availability for any respite beds. So I think that's another impact that we haven't necessarily teased out. I don't know, Mary Jane, if you have any sense of whether you folks are doing that as same as you were before. Is that sort of low on the totem pole for you guys?
Well, I don't want to say it's low on our totem pole, but it's hard to bring in respite when you don't have enough staff, because then that's just a short-term person.
Right.
And then suddenly you have more staff that need more hours and you don't have the people, that they need to care for. But I'm sure it is difficult. I feel like we've been pushing our census, and whether it's respite or not, we've been pushing our centers to increase their census. And so it's really tapping them out. I know other companies are doing the same.
So for some families, whether it's somebody in the long-term care system or just a family who is getting respite services from the AAAs, not having that availability of workers either in the home or in the facility-based care is also an impact on those families and the person, because getting that break once in a while or being able to go to that family wedding or take that vacation is critically important to people being cared for by their families. So that's an issue that we've seen. I had a meeting this morning with 6 of my care coordinators up in the Waterville area, and they're really concerned about the unstaffed people. They do make those phone calls. I think, Michael, maybe it was you who alluded to, they're like, why are you calling me if you got nothing for me? But we do talk to them about lots of other things, like, are they considering getting vaccinations? And, have they signed up for LIHEAP? And, all those ancillary services that we try to wrap around people. And, giving them that little bolster of hope that maybe someday we'll have a worker for them. But, we haven't seen all the efforts, and they've been many on the part of the state, really move the needle a whole lot in terms of unstaffed hours. So, but I shouldn't say this, I'm gonna knock on wood when I do it. Our care coordination staff is full right now. We have all the workers we need. Our caseloads are much more manageable, but that's because we've chosen not to take referrals from 96 right now. We're keeping the people we have, but we're not taking any new referrals for a while.
Can you remind people, particularly people who are listening, what's 96?
96 is the state plan for long-term services and supports for people who are older and people with disabilities. It's Medicare. It's a Medicaid. It's a Medicaid service for people to support people at home.
And Tom?
It's great, always great to have Betsy go first, because I can say ditto. We compare notes and share war stories all the time. And when you were off and you texted me that your internet was out, I was going to say, I'll let people know. And one thing I wanted to cover was addressing not just the direct care workforce, but the care coordinators. That's where we saw the suffering. That's where we saw the lack of adequate payment and all the things we have to do for recruiting. We haven't hired a recruiter, but as Betsy knows, we had to dramatically increase payment, which adds to a huge overhead cost. But we've done one other thing. We had to address compassion fatigue and empathy burnout. because they were taking on caseloads of 140, 150 consumers per care coordinator, and then burning out when they couldn't staff their hours because the agencies don't have any people. And so that itself created a problem. So before, when you were talking, Betsy, about, you know, what the healthcare or the personal cost of insufficient direct care workforce, it's on the care coordination staff too, because they really care. They wouldn't be in this business if they weren't caring people, and they burn out. So we've had to take, you know, extraordinary steps to address that. So we suffer the same things that Michael and Betsy described. That's an insight that we hadn't really addressed with this group before.
Yeah, and I think those caseload sizes cannot be overemphasized. That those caseload sizes were probably double what they should have been for staff. And it really was a hardship, and we were losing staff. They couldn't take the stress of it any longer. It was just too much.
We also have had to stop taking new initials in Section 96 for exactly the reason Betsy's described. It's just, it was a high population. It was burning out. They won't pay enough to hire more people. So we had to stop.
There's a reimbursement rate issue there.
And what happens, do you think, to those, to that population? So, I mean, does every care coordination agency have they can say whether they're going to take those cases or not, those folks or not?
Yeah, actually what ODES has told us is that every practitioner has a right to limit their practice to the point where they can properly serve it. And both Betsy and I concluded that our agencies couldn't serve with new further or put at risk the population we're already serving. And we still already have, I don't know, about half as many as you, Betsy, but we still probably have 800 in Section 96, and you were
we didn't return any, let's put it that way. We didn't say, here, you can have these cases back. We kept the cases we had open, and at the time that we stopped taking them, we had over 2,000. So yeah, so it
may be a wait list that occurs.
Yeah, we don't know. We haven't been told. So.
Uncertain.
Angelina, do you have updates from DOL and DHHS, since Abby's not here?
Yeah, I've sent out to all of you via email some written updates from both DHHS and from MDOL, and I'm hopeful that you all got them. I've never sent written updates before in a committee meeting, so does anyone know if I did the thing okay? Did everybody get it? But I don't know that I can answer questions about the content. I will say that I'll like hyperlink them into the meeting minutes and hopefully get them posted in a place where everyone can access them moving forward, if that's helpful.
Are you able to summarize them or no? And that's fine if you're not.
I could definitely talk about the MDOL one a little bit more. The DHHS one is kind of a different world. So our MDOL update included just kind of a quick intro to, hey, when we kicked off a lot of our healthcare work at the beginning of our American Rescue Plan Act stuff, we had a lot of listening sessions, and that's how our different initiatives kind of came off. And then it's an update of some initiatives. So one update about healthcare training for me, just a website that's designed to help folks find the training that they need in a centralized place. We've seen a tremendous, like, for example, Washington County Community College has a really wonderful MHRTC class. It's asynchronous, and you can take the class from anywhere in Maine. But if you're a person who lives in Portland, you might not be looking at Washington County Community College. So healthcare training for me helps to bring all of that together, so that way people don't have to spend as much time looking for the classes that they want. We also provided an update about our tuition remission program. So many people find out about tuition remission from the Healthcare Training for Me website, where we can pay to upskill current workers to go from CNA to LPN, for example, or we can pay from folks to go from CNA to CNAM. We've also paid for a few folks to get their RBT, or their CADC, or their ACRE certificate. Notably for this group, what I think we've overall served more than 600 people, and 43% of the folks that we've served would be positions that are a part of the essential care workforce. So the other 57% might not be quite as interesting to all of you, but 43% of them really in positions that directly relate to this work. Then we gave an update about the healthcare navigators. So healthcare navigators receive referrals from a variety of places. One of them is the Caring for Me website. So a person can find out about the marketing campaign and then get connected to a navigator. Another one is the Healthcare Training for Me website. Also our career center consultants and et cetera. And that is designed to help attract people into the healthcare workforce. Our navigators are asking folks questions like, oh, so I hear you said you don't like blood. What about MHRT or BHP or something that doesn't necessarily, that was going to match your skills, your interests, and your passion? Our navigators so far have received more than 1,000 referrals from all the different referral sources. And I'm really proud to report that 107 of them have been referred to training opportunities, 151 to support services that can help them kind of get across the finish line there, and then 103 directly to employment without needing additional supports. A majority of the folks that they serve are interested in essential care workforce positions, although they serve people across a wide spectrum of places. And I added a section about a couple of different data resources that are available as kind of a opportunity, right, to have in a written update, just some quick links to the things you all have seen in previous meetings, but as a bit of a recap. And then Abby wrote the memo for DHHS, and the part of that intersects the most with my work, of course, is the Caring for Me website. And so Caring for Me website is still, and their social media outreach is still happening. And we've been exploring lots of different ways to try something else and see if it makes a difference in the quality and quantity of referrals, because we want people to know what they're clicking on, not just to click, right? To get them connected to the real live humans on the other end who can guide them into some of these career opportunities. And Abby's provided other details as well in her memo, but I don't feel like I have authority or comfort to necessarily speak about them because they're outside of my wheelhouse a bit.
Great.
So Angelina, I saw a PSA, I guess you would say, or an ad on TV about direct care workforce this morning. Is that something that came out of your shop? It was very positive. It was very, it was very promotional in terms of the field of direct care. But I
would love to take credit for it, especially because you like it. But I don't know that I can.
I'll have to watch for it. I'll watch for it again and sort of try to figure out who's, usually they'll give credit to who's airing that. But
if it says Caring for Me in it somewhere, which is then it would be originally the Caring for Me budget came out of MDOL's funding, and now DHHS is paying for it and continuing to carry on the work. So I feel like that's why I'm like connected, but I'm not, I don't get to take the credit for the good work.
Thanks.
Just, I don't know if it can be fixed and resent, but the links that are in the DHHS report don't work.
Oh, yeah, I can help with that.
That would be great. And I think we're expecting a guest at 3. And Angelina, did you happen to send her the right link?
I did send her the right link, but I also spelled her name wrong. So I said her name was Tamara. Her name is actually Tammy. So so she should be joining us any minute. And I know Dylan is on the call today, and Dylan has a quick update. Maybe we could fill in the blank with him while we wait for her, and I'll start texting her to make sure she's got everything she needs.
No, I was just going to move to Dylan. I just was checking in with you though to make sure she had what she needs to get in.
Not Tamara, Tammy, but yes.
Hey, Dylan.
Howdy. Hey, so I've got a brief and fun update. So I'm going to share my screen really quick if I can. Yeah, okay. And share. Okay, everybody see the my MDOL screen here? Perfect. Okay. So this is not live yet, so there are a few changes I'm hoping to make to this, but this will be the committee website. So this has taken some time to get together, and I am not the most technologically savvy human being out there. But this would contain, you know, as you can see here, the link to the law language. It'll have all the committee members, and I wanted to note that I'm planning to move you, Jess, and Catherine up to the top. Just to either way, you know, it shows who's chair and you know what the sort of statutory language that sort of designates each individual. And so underneath that, and I just put this in here to kind of test that it works, which it does. But we'd have links to all the meeting recordings, meeting minutes. So the sort of the notes that Angelina was talking about earlier. Yearly committee reports would have a spot here. And I was also thinking for those quarterly updates, we could add another section just to delineate between the two. And then we'd also have the sort of interested parties link at the bottom, which would like automatically email, or not automatically, but would populate an email with our dedicated email address for the committee. So if we could easily add folks to the interested parties list, and hopefully it'd be a pretty seamless operation. So that is like the very quick update on the website. You know, I think very, very soon, once these changes get made, the ones I was listing, we'd be able to get this live. So you could send, you know, members of the public, you know, to this website, and potentially we could have like I mean, I think it would make sense to have a meeting schedule and that sort of thing, but like the smaller details that make this, you know, that provides all the information for members of the public who want to know about the good work happening here.
That's great. I think it's terrific. I would say, you know, alphabetical order is great for the committee members. I don't think we need one over the other, although I will say, you know, keeping the senator and representative up front is always good.
Awesome.
We like to keep them up front.
They're good folks.
Can I just so just a correction on my name spelling. It's an E. No, that's okay. I think it's spelled wrong on everything in here. It's an E instead of an O in the middle of bed.
Oh, geez. I'm so sorry, Catherine.
That's okay. No, don't worry.
I will make some corrections here and also update our materials too. And that I mean, the same for anybody else too. I try my best, but I am not perfect. So whatever I can do to make sure you are represented correctly here, let me know. Happy to make it happen.
Just one thing for me, Dylan, Seniors Plus is one word, no space.
Oh, very good. That's great catch. Thank you, Betsy.
And the P is capitalized.
Got it. But yeah.
Any other
sorry.
dates for Dylan?
Maybe when it's, I was saying, maybe when it's live, Dylan, if you could send it to all of us, and then we could just look through it and be the guinea pigs before we make it public.
Makes a lot of
I would be happy to do that.
It makes a lot of sense to me, and just based off of what little edits we found here today, I think that's a great idea. But thank you everybody for having me here, and yeah, I'll drop my email in the chat, so feel free to reach out for anything.
Great, thank you. And Tammy, thank you so much for joining us. I'm Jess Maurer. I'm the chair of the Essential Workforce Advisory Committee, and we're statutorily created committee that exists to really pay attention to and monitor the growth of the direct care workforce and efforts to grow that workforce. And we very specifically, the folks in this room, sort of represent the entire continuum of care for older people, from the homemaker program all the way to nursing home level of care, as well as people who are providing care for people with intellectual disabilities, physical disabilities, and also behavioral health challenges. So we're we're talking about a broad category of workers who are essentially providing care and support for anyone who needs it, all kinds of people in all kinds of settings. And we are aware that there are significant workforce shortages and people who are going without the care and support they need, and have been for many years. Most of the people in the squares, with many more who are missing, for many years have been working to really elevate these jobs, and get more resources to them, higher pay, higher benefits, better working conditions, more full-time work, connected to a career ladder. That took a long time, sort of even helping people to understand that a personal support specialist who does home care work in this, prior to this work, literally was never considered a person who should be considered for, sort of moving into a healthcare job. And so these sorts of things have really changed. And in our last conversation, we said, I wonder if, for years, these jobs have been talked about as dead-end jobs, right? And so we don't promote them because they don't pay a livable wage, and they're not connected with any sort of career pathway, and that has changed. And so we're like, well, do career counselors in high school know that? Do they know that these jobs, particularly in the last 6 years, have become better jobs, and now better connected to other healthcare jobs? And are there opportunities to have conversations with folks who are shaping the decisions of our young people in terms of where they start their working career? Are there opportunities to sort of educate and engage in those conversations? So that's why I reached out, and I'm so glad you're here. And if you wouldn't mind just telling us who you are and what you do, and your thoughts on that lead up, that would be great. And then we'll just have a conversation.
Oh, sure. Thank you for having me here. It's great to be here. My name is Tammy Ranger, and I'm the Director of Workforce Development and Innovative Pathways at the Maine Department of Education. And this is a relatively new office. It brings together adult education, career and technical education, extended learning opportunities, which I'm not sure how much this group knows about those. When I heard ELOs, I'm dating myself here, I thought of the band. So that's another team within our office, and also early college. So these 4 teams are under the umbrella of Workforce Development and Innovative Pathways, really looking to bring together our expertise, our resources, so that we can open up learning opportunities for students and also help meet Maine's workforce goals. So I appreciate being here, and I wanted to also come, to hear more from you, to find out. And that introduction was great of the need. And I read a little bit of the background information. Probably like all of you, I've been in a lot of meetings today, trying to read in between meetings. So anyway, I was thinking about what the information you would be looking for. And of course, you are probably already aware that, with CTE, we have our CTE programs that, that would address this need, this sector. And then also, I was reading in your information that you're involved with the DHHS and the Department of Labor. And so I'm thinking about our adult education team is involved in the healthcare training for me portal. And I checked in with our adult ed director today. I said, how many students do we have engaged in that work, in those trainings? And as of right now, it's 264 students or learners are engaged in those programs under healthcare training for me through our adult education providers. And then the other piece is thinking about, I don't know, do any of you know much about the extended learning opportunities? The ELOs. It's not a band. It is a band, but that's not what we're talking about here. So in many states, I think except for like New Hampshire and Maine, it's called work-based learning. And in Maine and New Hampshire, it's ELO work. And so it is looking at helping students at a younger age. So CTE usually is 10th and 11th grade. And many students who maybe can't get in, they're on a wait list for CTE, but it helps them explore their career path, their career interests at a younger age. And so they are opportunities for credit-bearing experiences, either core credit or academic credit, for high school kids to follow their interests. And and again, receive credit, definitely elective credit, and as awareness is spreading, earning core credit. And so thinking about the conversation today, I'm going to back up a little bit. With some of the Maine jobs and recovery funding, the DECD has the Maine Career Exploration Program, and a portion of that funding came to the Department of Education, 5.6 million, to expand or create extended learning programs in schools. And so that program has been underway now for a year, and we're gathering data. And just thinking about the topic today, I looked to see, because I was sure we had an example of a student that did an ELO experience in the field, the direct care field. And so I'm looking over, I'm not looking here, I'm looking at my other screen. In Brewer High School, if you'll humor me, I'll read you her synopsis. So there's a photo of a student, and I can drop this link in the chat too. We have developed a relationship with a local rehabilitation facility for them to provide a paid training for the state of Maine CNA exam. We have had a student who is in our alternative education program register for this class, complete the training, and pass the state exam. She was offered a position with the facility and is happily employed in a career field that has been her dream since she was a child. And so that's an example of, this isn't a CTE student, this is somebody that did an ELO and achieved a certification and is now out spreading the word about it. And I know that's one example, and we're looking at the need is much greater than that, but I wanted to make sure that this group was aware of the Extended Learning Opportunities Program and the growth that is happening in that program. And then the other piece that you had asked about is a piece that we're working on, is connecting to school counselors. So in the department, and I know one of my colleagues, Julie Smythe, is our Director of Office of School and Student Supports. And she often connects with school counselors, her team, more on the social, emotional, mental wellness piece of things. And so our office is in the process of forming relationships and seeing how we can best connect with the two organizations in Maine who represent school counselors. So you've got the Maine Counseling Association and the Maine School Counselors Association. And we've been really focused on working with them more about getting information out about early college and credits with a purpose. And so it's interesting that your request came around the same time that we're in the middle of forging these relationships to see how can we were thinking more of that in that way, but certainly to raise awareness about the need here as well.
And CTE stands for Career
Career and Technical Education. Yes.
I figured, but I just wanted to.
I know better than to use acronyms.
Oh, yeah. Well, that's all right. They're just different than the ones we hang out with. So do folks have questions for Tammy?
And certainly, yes, I have my notes, and I can we have our team meeting tomorrow, and I can certainly gather some more information. I saw too that you're monitoring the progress of quantitative data on the number of people entering this profession.
Well, we're trying to. We don't have any good data, so we're still sort of on the anecdotal. We have some limited data, but I think also, sort of hearing, and I think one of the things we're really interested in doing is how can, and so one question I have for you, and I think it's, maybe it's a bigger question for these other organizations as well, is how do you work with young folks who are sort of the types of things they want to do? Like, do you like, because care comes up a lot. So when I think sort of going back to the beginning when we first started this work, the long-term care ombudsman had a long conversation with some direct care workers, and then DOL did a really great survey, and with 700 plus workers who are working in this field, and that was the thing that came through, right? Is that these were folks who love these jobs because they care. Like, that's the word that even if they're in technically support jobs, right, that where they're not doing any hands-on sort of care, but it is that they care about the people that they are serving. And I've been wondering about particularly tapping into young people who have who have that desire to move into a caring profession. which can be healthcare, right? I mean, in the end, could be a doctor, or, you know, a PT specialist, or, you know, any sort of thing. And these are just such great entry level jobs to sort of get hands-on, you know, sort of experience in a caring profession, understanding, you know, most young people are going to move into something else, but sort of thinking about, you know, how could we as advocates, Department of Labor, you know, where do we tap in with you, DOE, to make sure that these jobs are on the radar? Like how do we do that? Where's, you know, like the place where we can be most effective at making sure that people engaging in conversations with younger people about their future, you know, that this is seen as a starting place.
Sure. Well, I think too, and definitely, I think talking to school counselors, and I'm also thinking of the growing number of extended learning coordinators that we have. And we had a conference the summer of 22, and then again the summer of 23, just bringing together all the state ELO coordinators who have this information, and they do interest inventories with students, and they also present careers to students that students may not have thought of. If a student hasn't thought about this, but then it's presented to them and then they learn a little bit about it, that could also pique somebody's interest. So, and we've got a growing network of ELO coordinators. In addition, you know, when you think of school counselors, I'm also thinking of ELO coordinators. Career and technical education, we have funding now for middle school programs, and so 7th and 8th grade, and so thinking about connecting with our middle school career and technical education programs. What I would like to do, I knew this would be a conversation, I would like to bring this information back to our team, the 4 coordinators of the teams that I mentioned at the very beginning of our conversation, and pick their brains a little bit more. I'm also thinking, I mean, I'm sure you've thought about career fairs, and sometimes a student might not go up to an information booth because they think they don't really know enough about it to know that they might be interested in it. So I wouldn't say, you know, it's not, there's no silver bullet, but I wouldn't say that that's the only, you know, that would be the only answer. I'm also thinking about, I'm thinking about junior achievement, and they have junior achievement has guest speakers go in and talk to students. And so looking at the connection with junior achievement and having somebody, especially as you're talking about people that are doing this work, they're very, very passionate about it. You know, I taught middle school for 20 years. And when I talk about teaching, I know that care, the passion that comes through, and that goes a long way in talking with young people. And so I'm thinking, I don't know if there's been any connection with junior achievement, but we're trying to do some work with them as well. And we could make that's something that I'm thinking of that would, I think, make it a good connection.
I have a question. I think those are all really great ideas. And I'm thinking of, you know, I was thinking about the career fairs like that students get introduced to. And I also know that not all students go to college, and not all students go to college right away. A lot of folks take gap years. And, you know, these could be jobs. I mean, if we get a year out of somebody, it's great, honestly. And, you know, but they might stay, you never know. But so I think about that, and I also know that in some states they have actually got a high school curriculum for students who come out of high school with a certification in personal care, and you know, they can't. And I think some rules it's 17, some rules it's 18 that you have to be to start working in the field. But you know, is Maine Department of Education, do they have any of that curriculum in place in terms of offering that for students who might want to work for a bit before they think about higher education, or they may not be thinking about higher education in the traditional sense, but rather going into the workforce and then deciding, you know, do they want to advance by getting, you know, professional certifications and that kind of thing. So I think there's just a huge amount of exploration that could be done around this, around getting people interested at an earlier age.
I agree. And, you know, we've got in the Department of Education our life and career ready standards, and really looking at exposing kids in a meaningful way at a much younger age. And something that we're looking at right now is, you know, we have after school programs. And so what if we had our after school programs, and we're looking at kids in grades 4 through 6 with a focus on career exploration. So you're in 4th to 6th grade, really trying out a lot of different things. And so to answer about the credential piece, the only one that I'm aware of, and I'm doing my homework, is through career and technical education, getting an industry recognized credential with the 350 hours through career and technical education. But I've got my list of questions to bring back to our team.
That's that's really great. And I see your hand up, Catherine. I'm going to come right to you, but I just wanted to say in response, Tammy, that another piece that the DOL survey of workers found was that a really large percentage of current direct care workers were exposed to care at a young age, care of older people or care of disabled people at a younger age. Their parents took them to their parents worked in the field or took them to a nursing home or, had them volunteer. That is, so I just think that experiential learning is a really critical component.
Absolutely, yes. No, when I taught 7th and 8th grade, we went to this is in Skowhegan, we went to the Woodlawn Nursing Home and Rehab Facility. And I taught students who were, I was a reading specialist. So I taught students who maybe 7th grade were reading on like a 2nd, 3rd grade reading level. And, it was such a wonderful relationship because the kids could go and read in a very non-threatening environment, and the residents loved it. And I think sometimes, and I know I'm preaching to the choir here, sometimes kids can be afraid if they think, especially if they haven't been around a lot of older people or people with challenges, they make up stories in their head that aren't true. And when they go and they meet them and they work with them, all of that just dissipates. And it was such a beautiful, beautiful, strong bond. So 100%.
Yeah. Catherine.
But my dog, for some reason, is barking a lot, and she never barks. So if she's barking, I apologize. I'm over here going, what is going on? So fascinating. I think, I just feel like there's so many opportunities here for, just newly sort of being adopted. Was part of the flexibility during the pandemic was direct support professionals are able to be credentialed at 17 and working in the field. I think that it is like like Betsy was saying, it's a really good gap job, but it's a really also good job while you're doing something else too. They're very, a lot of the jobs, some of them are really flexible in their scheduling. So while somebody's in school, it is often, I think somebody else said too, starting off point for people who, then progress in their career. I worked with kiddos when I was a kiddo myself, basically, but working with kids in residential care, and so if you talk to people who have really become professionals in this industry, many of us, if not most or all of us, have started as a direct essential care worker. So I think that is really cool. I live in Orono, and I was just reading yesterday about how Old Town it's the only school in our area, but they have the 9th and 10th graders do an exploratory class within the high school for career and technical CTE, or I had no idea what those terminologies were before, and I don't know how prevalent that is around the state, but I just thought that was such a great thing. Not completely bringing back the trades into the schools like they used to be when we were younger, but it is a step there. And then just interested in the extended learning coordinators. How is that organized? Is that organized at like a school district RSU level? Is that organized and coordinated at the state level?
It's both. We have an ELO specialist at the Department of Education, and then who supports the ELO coordinators within school administrative units. And so there's that piece of the coordination of that. And then also thinking about your comment about the exploratory programs, you're spot on there. That's CTE exploratory programs for freshmen is the greatest growing CTE program for definitely, I think I know for sure the last year and probably the year before that as well. So you're talking about ninth graders in your school at Orono Middle School.
It's actually
high school.
It's actually Old Town.
Old Town, yeah.
High School, not Orono. Old Town High School, and it's 9th and 10th graders that take an exploratory CTE class.
Other questions for Tammy or thoughts?
I guess I have a question. It's probably goes to Angelina too, or just so I think like there's a DOL and DHHS collaboration on the Healthcare for Me and the tuition mission and the Caring for Me campaigns, and I just am curious as to the collaboration between those entities and DOE and how much work has been done on focusing on the future workers as opposed to like the workers we could get right now. And is that something that can be expanded in some way if it's not happening?
Happy to give like some context from my work, Tammy, and then maybe you can fill in some additional gaps. The Healthcare Training for Me website is really the space where our collaboration between DHHS, the Department of Education, the Maine Community College system, and the University of Maine system happens. There's a core team of folks who meet at least twice a month to kind of talk about challenges to a kind of high level, getting folks connected to the training resources that are there. And there's a lot of streamlining and stacking and thinking about grading funding. So, for example, in the Maine Jobs Recovery Plan, the Department of Education didn't receive very much money, but the Maine Community College system did. So they've been able to kind of do a lot of subcontracting to DOE in order to meet the needs of students across a variety of things that DOE can deliver the training on. And so there's been a lot of conversations about like planning towards the future. What are some of the gaps? What are some of the needs? Most of our plotting and planning comes from requests from employers and individuals that we're currently unable to meet. I did just receive a pretty fat stack of requests from our Department of Ed, or adult ed, at least, providers who are very interested in exploring additional cohorts that we might be able to fund either through MCCS or through MDOL. And we have a meeting on Friday to try to figure out who can pay for what and how we can make sure everyone's needs are being met. Traditionally, there's a lot of barriers, and like if Westbrook and Portland have a CNA class that start on the same day and they are both Tuesdays, that doesn't meet every learner's needs. So we've been doing a lot of coordination there as well to see, could Westbrook start a month later if Portland is starting this month, or could maybe Westbrook offer a night class if Portland's offering a daytime class, in an attempt to really meet learners where they're at. And I think that work led by Megan Dichter and Steve Erodi is how I say his last name, maybe not quite right, has been really powerful in making sure more people have more access to the programs that have traditionally exist, and that those programs are fully funded, whether it's with WIOA providers, CDBG funding, MJRP funding, pick a funding source. We're really working together to make sure that there's the classes for these programs exist, are not all at the exact same time on the exact same day, and fully funded. And Tammy, maybe you've got some other details to fill in, because my connection is really only with adult ed and not necessarily in the high school or other programming.
No, as far as healthcare training for me, that, I mean, you captured that really, really well. And the numbers that Megan gave me earlier, Megan Dichter and Steve Aradoli, yes, 264 students now, but also definitely the interest. And if there were more availability, those spots would fill up.
And Angelina, in those, bi-monthly meetings, I mean, how much, I guess, education can be transferred over, just in terms of, because it's one thing to know, oh, we've got this website and this is sort of, at a 30,000-foot level, couple minute overview, this is what's being done, or is there more, I don't want to say selling, but again, the education piece around all that we have, because again, what we put into that website, when we put into this continuum is quite a bit. And so trying to just think of, just in terms of sharing that information so they can best, again, not sell this to someone over another program, but at least inform, make the best connection based upon the services that we have. I'm just feeling like that could be a unique opportunity for this group, just because it spreads such a big continuum. Again, within my sector, there's no certification, no education needed. That could be started coupled with that educational piece to move on as a career trajectory, right? So there's a lot of pieces like that to try to, I guess, inform someone to help them make an informed decision around career paths. I guess just, kind of selling it that way. Again, not trying to sell it over another one, but properly educate, I guess, is the way I'm trying to put that. So that's just, I don't know if that type of level takes place as the opportunity or avenue for, but that's just something that comes to my mind.
I think that's really the piece where the healthcare navigators from the MDOL team shine, right? Is the person comes in, they're like, I really don't want to go back to school, but I think I want to work in healthcare. And okay, well, what could you do? Because you don't have to go back to school to be a home health aide, although you might need like your employer to give you a CPR training or to help you get to do things. And so our healthcare navigators are the real live humans on the other end of requests. So people will fill out a request and be like, I can't find it. And they're right, they can't find it. Every single community college uses a totally different platform for all of their classes. So we're manually scraping this data in from MCCS. DOE has been a really wonderful partner in terms of helping us get the data about new classes as they're launched and before they're launched, so we can help enroll them and fill them up. We've run in the past the problem where cohorts of CNAs can't go because there aren't enough people in the class. Like no one wants a class with just 3 people. That's not a class. That's like a private tutoring session. You got to have like 5 people so that one person can drop off and it's still a class. And so, with DOE, we're make sure we get the classes posted well in advance. And we have the real live humans who are like, oh, well, you want to start tomorrow? Well, tomorrow you could go to Biddeford, or, oh, you want to start in 3 months? Well, in 3 months, you could go to Westbrook and you could get that same thing. I'm sorry to use all the Southern Maine references, but they're the towns that came up quickest in my brain with my Southern Maine bias. But that work is happening statewide. So our webpage is not great. It was designed to be a quick fix because it was really hard to get that information. We're manually adding it, right? Every single week, every single month, we're adding new classes as they come up for people to find it. Our dream is to make it more systematic, but because everyone's using a different class system, and we can't help people. I mean, they have to get accepted to the University of Maine to the program, or they have to get accepted with their CASA score to the program at Portland Adult Ed, but at least to let people know that it exists. And it comes with that real live human who's like, oh, your problem is you think you need a CASA score, but you probably already have one. Let me reach out to a navigator at Adult Ed who I personally know who can help make sure that they've got your paperwork and the stuff you need to help you really get enrolled. And I think that's the real secret sauce of the collaboration, is having those frontline staff, the navigators across the systems at DOE, at MCCS, and at MDOL know each other and are able to make those warm referrals. Most of the time, and of course there's always something that goes not quite right, or a person who doesn't answer their phone, or a vacation that happens, and we've been doing a lot of work to try to make sure no balls get dropped, particularly because there's been some funding confusion. Like, who will pay for it is an interesting question, and all of us and many folks have different funding stuff that we can stream, and so we've been doing a little work to see how we could braid the funding better, so we could tap multiple funding streams and make sure we get everything spent and invested in our state in a meaningful way. I don't know if that answered your question, and I hope it did.
That's helpful, thanks.
Yeah, I just want to say, so I can do this briefly, ditto echo on anything that can lead the path on CNA, because I think it was Betsy who said a gap year. Coming out of high school, I'm not sure I'm ready for college yet. Get the CNA and go work. My own daughter graduated from Wesleyan. I think her degree was psychology. Wasn't sure what she wanted to do. She got a CNA. worked in the trenches and said, okay, this is what I want to do. And the career path was she's now family nurse practitioner, board certified, working in East Boston in a health clinic there. That is a career path. That was essentially her gap year after college. Those are two. Chapter 2, second career people. People who we used to think are retiring. Nobody's retiring at that age anymore. That's a whole bunch of workforce there. But helping on that navigation, the information referral, Angela, you were talking about, essential for where do I get it? What are the requirements? And how can we pay for it?
And great part-time jobs while you're in college.
Absolutely.
Right.
You go out of high school and say, I'm not really sure. This morning's New York Times, the Daily. Is college really worth it? Well, take that gap year and you'll figure it out. Yeah, it is worth it. So, but go get this, and then while in college, you would have this. Even if you're a public education, it's still an essential need. And there you go.
Well, and you all should come, to our conference next week, where we're talking about, this new map of life that suggests if you've got 30 years, you've got to put it across the continuum of your life. And so we're going to go to school differently. We're going to learn differently. Maybe you don't go to college until you're 28, until you've had some real life experience in different things and really can, how many college students, they're like, yeah, I don't know what I want to do. I'm just majoring in, English because it's what I like, or, who knows what they want to do really. When some people did, I knew I wanted to be a lawyer when I was 13. Okay. And I went and I became a lawyer.
That's why I like you, Jess.
So anyway, but mostly people don't know.
Hopefully they do.
Yeah. And so I'm going to ask two questions. And Tammy, you mentioned your connection and work with DOE and DECD. And I haven't heard, Angelina, you mentioned DECD a lot, and the work jobs plan that we have. And I fear, I was just talking to the folks over in New Hampshire, and their direct care workforce is like front and center integrated into their overall jobs plan. Like it's part of the plan. So this is like a two-part question. One is like, are we working with the ECD? Are, these jobs being talked about on a regular basis? As part of, Jobs for Maine's future kind of conversations. And then secondly, and now that I have the, have we been able to create something as simple as this? Because I haven't seen it if we have. So this is from New Hampshire, and I'm not entirely sure. It's I know my box is in the way. I'm going to try to get rid of it. But if you can see this, it's got schools, mental health, licensed residential facilities, home care, home health care, consumer directed, developmental disabilities. And it's like these are the starting jobs. And this is where you can climb up, and you can go this way, you can go that way. But it's a visual to help people sort of understand where they go from one place to the other and how it all sort of fits together. And I just wonder if we're, because I think, where there's been some talk about, sort of pushing people in this direction. Well, I think we should show people in a visual way that this is the starting place. This is the starting block, these jobs, because you can, if you want to work in with this population, right, move to this next place. Are you going to show me you've got exactly the same thing? Oh, there you go. Similar. I think it's confusing, by the way, but
I know from our end, we've piloted like 4 or 5 different versions of this to see if we can get a lot of questions answered, and are still looking for the perfect version, because and is there a perfect version for certain audiences and a more perfect version for other audiences? I think is a part of the analysis. We're trying to figure out who reads the PDF, what are their demographics, and who lingers on this page the longest. So that way we can maybe build a better one that serves everyone, or a couple of different versions that serve a couple of different groups of people so they get the stuff that they most need. So this is like round 4, and we're still gathering information to figure out the demographics of who used it and how long they lasted, to see if we can get it more right for more people more of the time, or more right for certain demographics.
Yeah, it just seems very confusing as opposed to like very simple. in terms of like entry, low barrier entry, like where I'm starting from if I have nothing, you know, like help me figure out what my first step is, kind of thing.
Can
I
I
think
just point out too that there's like no, I think the adult mental health is labeled wrong, perhaps, or behavioral health. There's just no reference to people with intellectual and developmental disabilities and their supporters. Would be my point. And there seems to be 2 references to mental health, behavioral health. So I don't.
well, and I'm just looking at this, and it still would suggest to me that I know that I want to go into oral health, that I don't even know what allied health means, by the way, and I'm 57. You know what I mean? Like, I don't know that any of those systems are something that an 18-year-old understands. Is what I'm trying to get at, is that, you know, like starting at the most basic would be great.
That second link. Oh, there's how many links do you got there? Holy moly.
15 links.
So many, because we were trying to nail it, right? And we get a lot of feedback from people that this didn't work for them and that didn't work for them, and they want more, they want less. And one day we're going to have it in the way that meets many people's needs, maybe.
Nice.
Yeah, and see, I guess I'm still saying, like, you know, provider type or education type, like, you know, like I'm still like getting at that gut thing, which is that question I had about care. You know, like I wanna work with this population, or I wanna, like, where, you know, like where it's not necessarily about where I don't know about associate's degree, you know, like, or about degrees. I just want to know kind of like where, there you go. And are those supposed to be like a pathway? Like you start at the beginning?
Which one are you looking at?
And the final link that says Maine labor, healthcare, career pathways. It's interesting because you could start in any of the light on the white, anything in the white without any training. You could do anything in the yellow with very short-term training. And so it's kind of, I think it'd be right. Another version of this is more of like a journey map of like, if you choose this, then it opens up these doors. If you choose this, then it opens up these doors. We haven't quite nailed the perfect version that meets the questions that come after and the outreach, but really excited to one day get there.
Maybe the young folks that Tammy could put together a group of young folks who could reflect on a couple of versions and whether it makes sense for them.
Yes, because sometimes what we think makes sense doesn't make sense to them. I'll drop in the link to, are you familiar with the Department of Labor's student dashboard? I'll drop that in the chat.
Jess, can you also put the link in of the thing that you were showing? You shared your screen on.
You bet.
Please.
And I'm sorry, I'm going to have to hop off here in a minute, but I'm very interested in follow-up and connecting folks with some of the people that we work with, our ELO coordinators and some of the organizations that we've talked about. So thank you for having me, and please reach out with any questions, and I look forward to collaborating. Thanks.
Thank you.
Thank you.
Well, that was a very great conversation. And I've lost my thing right now, so I will find it and we'll share it. Apparently I've opened all these new browsers. So we only have 20 minutes left. I always think, God, it's gonna be such a long meeting. We're never gonna take all this time, and here we are. I know. So I think, Angelina, you want to talk about our meeting in December. And we have a proposal also about a focus of that meeting. So do you want to start with nailing down the date? I agree with you. The 20th is never going to work. I'm going to be on vacation.
And I sincerely hope everyone is on vacation on December 20th, or at least getting ready for it. If our topic might be if our focus topic might be reviewing the benefits cliff, I reached out to Sarah Griffin. She's a consultant who's been doing a lot of the work with the on it, and she's been training all of the trainers and really like the lead behind it. I asked her if she was available on December 20th, and the answer was no. So I'm curious if you all how you all might feel about a December 6th meeting in lieu of a December 20th, which does two things. One, and make sure Sarah Griffin could attend if that's the topic and that we want to do. And two, gives me more time to produce our annual report, which needs to be filed at the end of the year, which I think could be a really helpful thing. Last year, the annual report snuck up on me. And so I would like to not be snuck up on this year and have a little bit of time to draft it, get some feedback, and get it across the finish line with that represents the work that you all are doing in the best possible way. So questions about this, I'm thinking same time, like that 1 to 4 time frame, December 6th, but open to any suggestions, preferred dates, or other ideas, but just trying to stay away from the holiday season and build a little bit of extra time.
It works for me.
Works for me.
Yep.
Same. In the afternoon, it works for me.
Yeah.
Yeah, I don't have it at 7 a.m. That's when I have a dentist appointment. Lucky me, right?
Yeah.
That really bites, Betsy.
Yeah.
7 a.m. I know.
It's funny. Is it at 2:30?
No, it's just a check.
See, I made Angelina laugh.
Just want to show Jess I was paying attention when I had Betsy's comment at the dentist.
I know.
Given the feedback from the group, I'd like to propose changing the calendar invite, and I'll update the Zoom links as well, if that's okay. And then we would keep the rhythm, I think, of every 3 months, 1 to 4 p.m. like on the third Wednesday or whatever the thing is, except for like the one exception of December 6th, which, unless you guys want to change it, want a new rhythm as well, which I'm very open to.
I think this is fine.
An exception and a continued rhythm then is you'll see a small tweak in your calendars.
Great. And are folks good? One of the specific duties that this committee has is to look at the welfare cliff. I will propose also that we're going to have someone from PHI come. They've done a fair amount of work on some of this with a couple of states and would like to have them present as well.
Those are great. I particularly in light of what Michael was talking about with his workers in particular, that being the front end of the system for so many folks, who would lose benefits if they work more hours. I think that's true throughout the system. Actually, it's not just on the front end, but I think that's a really critical piece.
No question.
And I love PHI, so bring them.
Great. All right. Any other questions or thoughts before we head off?
We do have a couple people in the
right.
audience. I don't know. I don't know if we want to see if any. Didn't we decide at a meeting we were going to offer public comment?
We are. Yeah. So let's see if anybody's got anything that they would like to offer or say.
And I have to shoot off. I apologize.
Members of the public, if you want to raise your hand, if you'd like to be invited to speak, I can go ahead and make sure you've got the floor. And if you don't have anything to say, that's fine too. But the hand raise button should be available on your screen, and that would notify that I should do something. And I'm really excited to do it if you want me to.
Thank you, Catherine, by the way, for reminding me. I knew that was there, but. Hearing none, why don't we adjourn the meeting for the day and say thank you very much. And we'll see you again in a few months. Well, we'll see you before then because we're going to do some work in between. Thank you. All right. Bye-bye.
Thanks, everyone.